Susan. Do you want to come up? Do you want me to introduce you, or you want to say who you are? Oh, okay. Good afternoon. I am Courtney Gatza. I am the social worker at the Indiana University Center of Excellence, and here to present with Dr. James on managing changing care needs over time.
And I'm Chris James.
Oh yeah, use the microphone.
I'm Chris James. I'm one of the neurologists here. I'm the director at the Center of Excellence here. Good to see everybody here.
Yes, thanks for joining us. So here's our goals for this afternoon. We're going to be covering approaches to care throughout all stages of HD with a clinical lens, and then also from a social work perspective, thinking about social supports and resources. So, and then the big thing that we hope to convey is how important communication is. And so making sure that you're letting your care team know, whoever that includes, what's going on. So having an open line of communication. And with that,
Okay. How's everybody doing? Good. So I see some friendly faces out there. Good to see you. Represent IU. For people that are from out of town, welcome. It's not usually this steamy outside. So apologize for that. I guess it's kind of happening all over the country, but so yeah, my name is Chris James. I'm one of the Huntington's doctors here at IU, the center director. And so what I kind of wanted to talk to you about is I'm going to kind of come at this from an approach of a physician. Courtney also, obviously social worker perspective. But it's most important, I think, for me when I'm seeing somebody initially, and especially in the early stages, is to kind of establish how much somebody knows about Huntington's disease, because otherwise it's kind of difficult to start the conversation about talking about it where, if you don't even know where to start. We have a lot of people that come in to see us, and some of them are very familiar with Huntington's disease. They grew up with it, they've dealt with it either from a spouse or partner, or a mother or father or grandparent, and they grew up with it, and they know more about Huntington's disease than I do. And they're all up to date on research, and they have all these questions, and they're just like, they know all about it, okay? And then we also have folks that come in that had no idea that Huntington's may have been even in their family. It was a first-time diagnosis for the family. It just kind of came out of the blue. Maybe they weren't close to their family, or maybe they were the first one in their family with a diagnosis. So it's important to know that, because that's kind of how we start the conversation. We also, with this, we want to do some sort of genetic counseling. We're lucky enough at IU, like a lot of other centers, we have genetic counselors that help us with this. But in the office, when I'm seeing folks, I certainly want to talk about the CAG number. It's often talked about. And for folks that are new to Huntington's disease, this is something that's really kind of foreign. They're like, what is this number? What does it mean? And so we kind of review that. And I'll just kind of review it here shortly. We talk about the main symptoms of Huntington's disease. So we typically will think of our three main issues with Huntington's disease, which are motor complications or movement disorders, cognitive issues, and psychiatric issues. And these kind of morph and change as time goes on through the course of the disease. And so what I'm going to do is we kind of broke this up into early, mid, late stages. It's important to know that as we're talking about these signs and symptoms of Huntington's disease, they're not just stuck in these certain early, mid, late stages. For some of the stuff that I'm talking about, I decided just from personal experience to kind of put them in certain areas from when I see them typically more often. So we'll talk about that. We review the stages of Huntington's disease in our early discussions with patients and families. There's a new staging system for Huntington's disease that maybe some of you are aware with, and I'll kind of just briefly go over that. And then people are curious about research, what's available, obviously everybody wants a cure. What's happening with research. So we review what the CAG number is, and so when we're talking to patients, maybe we've done the genetic testing, maybe we haven't, but it's important to know that people understand what we're testing when we're doing it. So when we do the testing, we get back two numbers. Most of the DNA in the human body involves two sets of genes. We call them different alleles. And so we're looking for a stretch of DNA on chromosome 4, where if it's too long, we then consider that the Huntington gene. And given the fact that we have two different alleles, two different genes, we get back two different numbers. So we discussed that Huntington's disease is an autosomal dominant disease, meaning you only have to have one abnormal number for you to then subsequently develop Huntington's disease. A totally normal test would have two numbers less than 27. So if you have a 17 and a 19, that's a completely normal test. If you're greater than 40, one of the numbers greater than 40, that's 100% abnormal. Assuming somebody lives long enough, then that person's going to develop Huntington's disease. Now, if you have a 36 or greater, that's still considered the Huntington gene, but it comes with a little asterisk, meaning that there is actually some evidence that shows that people with a 36 and a 39, between 36 and a 39, there is a chance that somebody does not develop Huntington's disease. We call that incomplete penetrance. And then there's this weird one, the intermediate range, which is the most confusing. So between 27 and 35, if somebody has a between 27 and 35, we call that the intermediate range. That individual will not develop symptoms of Huntington's disease in their life. However, because of how DNA replication occurs from one generation to the next, it's not a completely perfect system. And so it's possible that if somebody has a number between 27 and 35, that if they have a child, the gene that they give off to that child ends up being bumped into the 36 or greater category. Why does this matter? Because we've known for a while that there's an association between the number of CAG repeats that you have and the onset of disease. So we know that the greater your CAG repeat number, the more likely you are to develop Huntington's disease earlier on in life. This is not like a perfect system. There are more factors involved with this. There are environmental factors that we're not even fully aware of that contribute to the onset of disease. But this does give us oftentimes kind of a general idea of kind of what we're dealing with and when potentially symptoms might start. So again, we're talking about psychiatric or mood issues, motor symptoms, and cognitive issues. Now, just briefly, prodromal stage. This is a really kind of confusing stage. This is like, right before we technically diagnose Huntington's disease. A lot of times people will come in to see us because they're not sure if they have symptoms or not. Maybe they're having some more mood issues. Maybe they're having some more depression or anxiety, or maybe they're having some issues at home with relationships and things like that. And it's confusing to a lot of people. Is this the onset of Huntington's disease? And because a lot of the symptoms that they come in with are just a matter of just living in the world that we live in, right? So it's hard to differentiate that. And the reason why this is becoming more important mainly is because the opportunity for clinical research. So this is the new staging system for Huntington's disease. And the main reason why this has come about is to help to identify patients with earlier onset, very, very early Huntington's disease, because these are folks that in clinical trials and research are probably most sought after in terms of to be a part of clinical trials. And so what they did is, instead of having no Huntington's disease, what we typically did in the past was you have the Huntington gene, but you haven't shown symptoms. So you don't have Huntington's disease, right? And then you develop symptoms, and you have Huntington's disease. Now, there's sort of a stage where there's actually no clinical evidence of Huntington's disease, but there's some sort of biomarker evidence of Huntington's disease. And what that means now is usually MRI evidence, in particular two areas of the brain, the putamen and the caudate, show atrophy in those areas prior to the development of clinical symptoms. So stage 0 is you just have the gene, but you don't have any clinical signs and you don't have any MRI findings. Stage 1 would be no clinical signs, but you do have MRI findings. Stage 2, maybe you start to develop a little bit of chorea. Maybe you have some subtle eye abnormality changes. There's some subtle changes that we can pick up in the office where this would have been the onset of Huntington's disease prior to this staging system. And then stage 3, that's when we developed what's called a functional change. So that's when the symptoms get severe enough where they start to affect your ability to go about your life. And we use this total functional capacity scale to determine this, but ultimately between mild, moderate, and severe, mild is like most of these folks are still working some, they're still independent, they're living at home. Moderate is when we start to need to get on disability because we have a harder time doing our jobs. This is when we start thinking about putting the keys away because we have a harder time driving. And towards the end of moderate, this is when we need more help at home. This is when you need more services at home. And severe is when you really lose your ability to kind of take care of yourself, when you're really dependent on somebody else to take care of you. So, early HD. So, breaking this up into our 3 categories, the main issues that we deal with in early Huntington's disease for our motor symptoms, the main one is the chorea. So this is the abnormal twitching, involuntary-like movements. I also included something called bradykinesia. We're not going to talk about that one, but that's more towards juvenile Huntington's disease where we see that. But that's actually kind of the opposite. It's like a slowness of movement. More often than not, especially in adults, we're dealing with chorea or abnormal movements. How we go about treating this? For the chorea, there are medications for chorea. And this is important to say. There's a lot of, sponsors for this convention, which very much appreciative. However, just because there's an FDA approval of a medication for a disease does not mean that that person should be getting that medication, okay? As of now, and I hope that this changes very soon, we don't have a drug available to slow down the progression of Huntington's disease. So every medication that we give is really rooted in trying to improve the quality of life of that patient. So it shouldn't be an algorithm. If Huntington's, then start Ingreza, okay? If Huntington's, start tetrabenazine. So we use the fact that some folks are really bothered by their movements, and if that's the case, we start something. If they're not bothered by it, or it's not significant enough where they're losing weight or they're not losing their balance, then we let it be. So although there are medications available, that doesn't mean you have to use them. In early Huntington's disease, this is when exercise is important. This is when we really want to set people up for success from the years down the line, developing some sort of good routine, exercise routine to maintain muscle mass. Cognitive issues, so unawareness, this is a common one. Oftentimes our HD patients lack some self-awareness in terms of some of their symptoms or the severity of their symptoms. Sometimes this can certainly affect sort of day-to-day life. Oftentimes people will describe, like, I'm having trouble with my movements, I'm having trouble with depression, I'm having trouble with anxiety, I'm having trouble with memory, but they also won't acknowledge that they have Huntington's disease. And so this is a really common phenomenon that we see, and it's different than just denial. Denial is more of like a psychological inability to cope with what's happening. This is more of like I don't want to say like more of an organic process because of the brain changes that are occurring, where it's just that self-awareness isn't there as much. The ability to multitask or simply just perform multiple things at once, this obviously affects people's livelihood and ability to work, and then and attention. So what I try to tell people is, especially with the multitasking, obviously take one thing at a time. We want to have a structured environment. We want to make things like as routine as possible for folks. And then with the awareness, mainly for caregivers, it's important to know that awareness may never come, okay? That fully self-aware state may never come for a lot of our patients. And then in the early stages of Huntington's disease, psychiatric issues, a lot of mainly depression, anxiety. There's certainly some irritability, which is kind of due to lots of different things. And then loss of emotional awareness. This kind of has to do, this is kind of psychiatric, kind of cognitive. We've known for a while that patients with Huntington's disease, they have a harder time picking up on emotional facial cues, especially. And so by having a harder time picking up on emotional cues, obviously you could see how that could interfere or be an issue with relationships and things like that. So with the psychiatric issues, especially early on, obviously we have medications to treat depression and anxiety. We'll go through a few of those. With the irritability, we want to limit potential triggers. Oftentimes there are triggers for people to become more irritable. If we can identify those, we try to steer away from them. And then the other thing to go along with depression and anxiety, also it's important to screen for any suicidal thoughts. Unfortunately, suicide is all too common in Huntington's disease, and we want to keep a lookout for that as well. These are some of the medications that we give for mood. Obviously, you'll recognize a lot of these. These are not just limited to Huntington's disease. These are commonly given to just everybody in the general population. Mainly for, I'd say, earlier in the disease process, we're doing a lot of SSRIs, so sertraline, Zoloft, the Lexapros, the Prozacs. These help more of our depressive and anxiety symptoms. They can also help with some compulsive behaviors, obsessive types of behaviors that sometimes we run into. And then if we need something with a little bit more potency to help treat mood or help to achieve more of sort of stable mood regulation, then we start using what are called neuroleptics. The ones like olanzapine and quetiapine, these are commonly used. The ones at the bottom, they have the added benefit of treating chorea as well. Essentially, neuroleptics, their side effect is that they cause a drug-induced Parkinsonism. And if you give that to somebody with a lot of chorea, it tends to slow down that chorea a little bit. So we like neuroleptics because they treat both mood, behavioral issues if they come up, but they also can treat chorea. And then these are medications that we use, some of them that we use to help treat specifically chorea. The 4 on the bottom were mentioned in the slide before. They help treat mood. Tetrabenazine, and then I would include also the newer ones, which are Austedo and Ingreza. These are what are called VMAT2 inhibitors, and they help slow down chorea. So they kind of soak up your stores of dopamine in the brain and help kind of slow down those chorea movements. Okay. Now we're going to kind of bounce back and forth here.
Little yo-yo action between the two of us. So, Dr. James and the physician approach is, a lot of focus on the patient. What I'm here to focus on is the patient and the family. So in early stages, some things to be thinking about. And when putting these slides together, I tried to, as we classify early, middle, late stages, there's some things that I tried to pull specific to those. What I would say is that it's a fluid process, right? And as Dr. James was saying, how we think about staging, where somebody is at functionally, and in the different categories is really the biggest influence on how we know where we need to be focusing our efforts. So the primary focus, I think, in the early stages is geared toward planning. I think it's an important time to have open communication and conversation about plans and wishes for the future. It can be extremely hard to talk about these things in this stage because life can still feel and look pretty normal, so it's hard to want to think about what we know could be coming and what is coming. So I try to frame things to think, conversations about advanced directives, living wills, and legal planning is something that we can all benefit from regardless of our risk for Huntington's disease. So these are conversations that families find a lot of value in. It helps make decisions easier when things evolve. So having that conversation early can be really helpful. The other thing to think about is services like speech, PT, OT. If there start to be early changes, it is not too early to start a support or a service. So as Dr. James was saying, somebody may not have full awareness as to how they're affected. So we really rely on input from other household members or family members with close involvement to tell us what is a concern. So one way to be prepared for an early appointment is to maybe have a piece of paper with the questions that you have, and don't be afraid to bring that with you. Additionally, the value of early care is building a medical record. So thinking ahead, knowing that disability could come in middle or late stages, it's helpful to have a medical record that reflects what changes have been happening, especially in the cognitive and mood symptoms. Additionally, building schedules and routines can be helpful. One thing that we didn't talk about named specifically is apathy. So apathy can be an early symptom where personality changes, and so having those routines and that structure is really valuable to help continue social interactions and engagement in normal hobbies and things that a person enjoys. I think I'm going to turn it back over.
So approaching sort of like this mid-stage, and again, this is very fluid in terms of how I'm describing these stages. For motor symptoms, what we're dealing with is, so we're dealing obviously with chorea again, but now we're starting to incorporate some other issues like balance issues and falls, as well as some speech issues. So not only again for chorea, we're talking about potentially medications, but this is when we really start getting a lot of the input from our therapist colleagues, physical therapy, occupational therapy, and speech therapy. So this becomes more and more important. In terms of cognitive changes, so some interesting ones that we see. So perseveration, our patients will, and I'm sure I've seen this. They'll kind of like really get stuck on certain ideas or actions, and it's really hard for them to kind of let that go. It could be like anything. Like it could be doing the laundry. It could be like germs. It could be like poisons. It could be like, their medications on time. And so people can really get stuck on those sorts of things. Impulsivity, they'll kind of do things without really kind of thinking it through. So there's this syndrome that's often described in Huntington's disease called the dysexecutive syndrome, where you kind of combine several different things that are going on. And an example of that would be like somebody with Huntington's disease at home that has to watch the same show like every single day, but that isn't really paying attention to it. And if you try to change the channel, then they get really, really pissed. And you're sitting there like, what? Well, you don't even care about this thing. So it involves like a combination of like obsessive, perseverative thoughts about this show. They're apathetic to the show. They don't really care about the show, but they get irritable if the routine gets messed up. And so you get all these things together, and this is like a really common thing that we see. And so, so it's important, I think, for caregivers especially to know, I tell people to kind of pick your battles. Like you're gonna have stuff that comes up all the time. And you gotta pick your battles. I try to tell people that to reserve the confrontations, especially for times when we're talking about patient safety. You know, if we're talking about safety, that's when it's worth it. This mid-stage, this is when oftentimes we have to start doing driving evaluations, or we start bringing up driving, okay? And whether or not we decide just to put away the keys, or if we start doing, you know, like every 6 month, every yearly sorts of driving evaluations, that's something that comes up a lot too. Psychiatric issues, so a lot of irritability, temper, aggression, and this isn't everybody, okay? This is definitely not everybody. This just happens for some folks. We talked about some of the obsessive behaviors. The compulsive behaviors go along with some of those perseverative, obsessive-like thoughts. So if it's like germs, maybe it's they're like washing their hands all the time, or it's like checking the locks in the front door, or whatever it is. Oftentimes they'll kind of appropriately kind of do an action in response to some of those thoughts. Also, the perseverative thoughts, in my experience, they oftentimes will accompany a loss of autonomy. So let's say if I tell somebody, like, it's time to put away the keys, then oftentimes there'll be a thought that comes up about like trying to prove to everybody that maybe, no, I can drive, and then you get this sort of like obsessive kind of like thought pattern associated with it, or it's like, okay, I can't hunt anymore, okay, no, I can. So that's something that we'll see. So for the psychiatric issues, obviously medications are helpful. We want to, again, encourage some structured routine. And then with the apathy, so apathy, like Courtney was alluding to, the apathy is different than depression. Depression is a sense of hopelessness and sadness, okay? Apathy is like, I don't care. I just don't care. And oftentimes it kind of drives the caregiver up the wall more than the patient themselves. And so I tell people to gently nag, okay? You don't want to push it too hard, okay? But to gently try to get them out the door. Because ultimately, a lot of our patients, when they do get out, they do have a good time. It's just hard to kind of initiate that. And I wouldn't rely on the person with Huntington's disease to initiate those activities, because it's not probably going to happen. What?
I feel like he stole my highlights. So much so that I just lost my train of thought. No, absolutely. I mean, I think, as I said, in early stages, as we get into mid stages, when lifestyle and routines at home are starting to change because of function, this is really where those early habits can be really beneficial for families, especially. But the awareness, the big thing that Dr. James said that I know is something that I echo in probably every caregiver support group that comes up, because usually the challenges that are happening are more difficult for the people at home. And so thinking about what's worth it, what needs to be addressed, and it's usually identifying what's a safety risk versus what is just a personal preference. I know one major trigger for family members can be around hygiene. Motivation to maintain self-care can change with Huntington's disease. And so really thinking about what needs to be a priority for this person's wellness and what are things that are just like my own preference, right? But recognizing that there is a decision to be made and aligned. One additional, I don't think it's up here, one thing that can also be helpful in mid stages is engaging other people that have a relationship with your loved one. Sometimes we hear messages better when they don't come from our spouse or from that one family member that's always telling us what to do. Sometimes we hear things better when it's from a more neutral place. The other thing that I think can be valuable in talking about symptoms and what's becoming more challenging is just talking about the problem and not needing to always say it's Huntington's disease. It can be extremely triggering if we keep telling somebody that it's their Huntington's disease, especially when we think about, kind of the awareness factors that we know are a challenge already. So do we need that person to say, you know what, yep, it's my HD, or do we need to work together to try to fix the thing that's becoming more difficult? I would say that this is a time, so as a social worker, always a big advocate for support groups and building a support system around yourself regardless of the stage, but definitely during these times when the function at home is changing, somebody is no longer working and now spending all of their time at home, they're not driving anymore. This is a really important time to make sure that we're not losing time for our own self-care. This is when we need to maybe ramp up the supports in our own life. I know one thing that came up in an earlier talk we gave is asking for help. A lot of people want to help, but what I would remind us is that people don't know how. So if there's a specific need that you're experiencing, ask somebody to do something specific. And I think that's okay.
All right, and then kind of approaching later stages of Huntington's disease, some of the motor issues that we start to struggle with. So chorea tends to kind of fall off in terms of something that is not like it's not important, it's just that there are some other issues that end up kind of being more important. So when people start having a lot of problems with their balance and they're falling, obviously that's important. When they're not having when they're not able to effectively and safely kind of swallow the food that they need, and they're at higher risk for aspiration, when they can't really effectively communicate like they want to. Issues just like incontinence and weight loss. So we're fortunate enough at IU, we have a multidisciplinary clinic where we're able to have neurologists and social workers and speech therapists and everybody kind of come together, and we're starting to utilize that more and more for our patients. It's a nice way to kind of have a team approach because these later stages can be so complicated. Medications for motor issues at this point, they're not really important. It's mainly the therapies. It's mainly, do we need a walker? Do we need a wheelchair? And is there a pain component occurring? Because this is when we start thinking about like, okay, what's most important here? We want to keep quality of life on our mind all the time. So this is where we get palliative care involved, especially if there is a pain component, because they are so good at pain management. Cognitive issues, again, all the ones that we've mentioned up to this point, it's not like they go away, but I'd say the language one is like really starts to become an issue in this stage, because it's not only like a physical difficulty with language. It's a cognitive issue. So it's not only it's finding your words, trying to think about what you want to say and fully express that to somebody, but it's also that they have what's called dysarthria. They have a hard time actually articulating the words. So it's a combination. I think it's important when we're at this stage and you're having a hard time communicating with folks, is you need to give them plenty of time to kind of express what they want to express. Because you can imagine if you're not given the time and you need more time to express yourself, that can be very frustrating. So we want to give folks plenty of time. Oftentimes we give people sort of yes and no types of questions. Sometimes that can be helpful. Cognitive issues at this point, medications really don't play a role. There is not really good evidence to support some of the medications we use in other neurodegenerative diseases like Alzheimer's disease or Parkinson's disease that help with cognitive processing speed. Haven't really shown to be that helpful in Huntington's disease. So it's not like a medication is helpful here. And then some of our psychiatric issues at this point. We deal with a lot of delusions and hallucinations. Medications can be helpful for this, depending on what it is. And I think it's important for caregivers to know that whatever they are, the person with HD, whatever they are experiencing, to know that it is strictly just part of the disease process, to kind of gently redirect, to not totally confront somebody and say like, no, that's not real, that's not true, that's not true. You kind of have to also pick your battles with that one too. And again, the safety issue, if you don't know whether to confront it or not, be like, okay, is this a safety issue or not? And then kind of continue to come back to that.
All right. I know it was on the slides for middle stages. I just wanted to go back and just say it out loud. When it comes to rehab services like physical therapy, occupational therapy, speech therapy, I think a lot of times we think about them as they're labeled rehabilitative services. So after something significant has happened, we think about a fall with an injury, we go to PT to recover. I do think it's important that whenever there are changes, again, that we think about those tools as ways to maintain and build on what's already there, that we don't have to wait for, some sort of injury or crisis or serious change to happen before we turn to those. So if those are changes that you or your loved one is experiencing, again, make sure we know about it in clinic so we can have that conversation about whether or not a referral to one of those providers could be helpful. There's a lot of benefit that can be had throughout all stages from that. So in the later stages, this is where we can kind of find comfort in knowing that we've had the harder conversations early on, and we kind of lean on what we know our loved one has articulated to us about what they want. It can be a continued conversation, and obviously with the speech changes, that is why it's harder to talk about these things in later stages, as you know. So if we have an idea early on, then we can use that to help guide decisions as they come up. And then just palliative care, I'm sure there's a couple of breakout talks this weekend about it. If you're not familiar with it and it's on the agenda still, I'd encourage you to look into it. I think palliative care is a helpful tool to kind of bridge the gap between managing things fine on our own to kind of the end stages where we hear about hospice or think about hospice. There's kind of a nice bridge with palliative care, who I usually describe them as being the team captain. Not only pain management, but they can help work with the patient to identify the goals and make sure the team is working together to achieve those the best that we can. So I tried to put together a little chart. And I think what is obvious from looking at this is really all of the interventions that we can do, we can really do at any time, right? So the biggest thing is it's never too early and it's never too late. The earlier we do things, the easier it is to avoid a crisis. And that's probably the most significant thing to take into consideration if we're avoiding doing something, is could this give us peace at a later time when things may be harder? So even though it may not be pleasant, are there things that we can kind of get in the open and be clear about now? I'm gonna move this slide, is that good? Got a picture? And then thinking about the whole family. I feel like these are messages that you're getting a lot this weekend, so not to be too redundant. I think the biggest thing, again, is seeking support and asking for help and making sure that we're caring for ourselves and the family together. There are not easy interventions or things that we can do throughout the stages, but building that community. We gave a talk about stigma this morning and talked a lot about building community and building the support that we need to get through things. So I'm going to leave it at that. I think we have a lot of time for questions, so. Oh, right. This is a recorded / live stream session, so with your questions, just be mindful of what you're sharing to keep confidentiality for yourself, or share what you're comfortable sharing, knowing it will live on in the interwebs forever. And then I think it's maybe on already. He said it was on. It's not on. Tech is coming. Anybody questions? Okay. 1 second, she's gonna bring, you gotta hot mic it here in a sec. Susan, right over here on the 4th row back.
Okay, he's got it, go ahead.
Okay. You mentioned the putamen and caudate that lowers during this. Now, is there anything that can be used to rise those?
Yeah, so there are two parts of the brain, the putamen and the caudate, that are shown to be the first parts of the brain that start to atrophy. They start to kind of shrivel up. So nothing we know of right now, but I know tomorrow is going to be sort of a big research day. So that'll be, all those sorts of topics. Hopefully, we get to a point where one of those really kind of sticks for us and is able to kind of prevent some of that what's called atrophy of the brain to continue. And the caudate and the putamen, those are like the first ones, and then the disease kind of starts to progress to the rest of the brain. But those are like the earliest findings that you can pick up on an MRI. So I hope we get to the point soon where we can slow that down.
Somebody over here. I think this gentleman in the blue.
Do you get out to train nursing homes that are caring for people with HD?
I can get out to nursing homes. I did just do a virtual in-service, so definitely we social workers are here to also offer education to other providers, and we're a resource.
Because I had 2 family members choked to death in nursing homes, and I think it's a training issue.
Yeah,
That all the doctor says they need to have their food parade. Somebody on the staff provided them a piece of steak or something, and none of them are able to do the Heimlich removal or whatever.
Sure. Well, that seems like maybe a general.
So that's a problem with nursing homes.
Yeah, no, absolutely. And issues around swallowing are certainly one of the conversations that are important to have early on. We don't talk about, plug your ears, Dr. James. We don't talk about like feeding tubes used as like a general intervention, but sometimes they're a choice that patients feel. I mean, it's not one of our first go-tos or something, but I've had people reside in nursing homes that had a swallow study, and we know that they need to be on pureed foods, but for quality of life purposes, that person enjoys eating food by mouth and is willing to take the risk of aspiration to maintain eating the foods that they enjoy. So there is a conversation. There's definitely always a gap in education, though, so it is also available to educate facilities. Absolutely.
Hi. Recently, at a recent visit, had our psychiatrist say that my wife was experiencing, although her depression and anxiety had been well under control with medication for the last several years, that she may be at a stage where it's increasing again. And in her case, prescribed an additional dose of Wellbutrin. I don't know how common that is. We did have some evidence in things she had said recently that supported that, but.
Do you mind sharing kind of like how long she's had Huntington's, or?
She is late stage. She had probably had her first physical symptoms in 2008, with depression becoming really noticeable in 2012.
So depression, in particular depression, that's mainly something that we deal with in the earlier stages. Mm-hmm. It's a little controversial as to whether or not depression is a major issue in later stages, or we're just misidentifying what that is. I think with our later stages, there is there's a significant amount of cognitive impairment that has taken place, where it's just not what we think of as our classical sort of like depressive like thoughts. And it sometimes, to somebody that's not used to dealing with Huntington's disease, it can look like depression, when in fact maybe we're dealing with something, again, like maybe they're apathetic, for instance. So I'm a little skeptical,
Yeah, okay.
but without knowing
No,
all the
that's-
details.
Respect your
Yeah.
experience, that's very helpful. Thank you.
While Susan waits for the next question, I was going to put Dr. James on the spot with a question myself. You talked about in the new staging, really geared toward research, kind of a focus on, you mentioned the MRI. And I know one question that I get is, do I need an MRI when a person is symptomatic? And I've always, we've talked about an MRI not being diagnostic. Can you kind of clarify what that means with the new staging?
Yeah. So we're talking about this. So if we're dealing with somebody, let's say we're in this prodromal stage where it's like maybe you have the Huntington gene and you're like, well, do I have Huntington's disease? We could, and I have this conversation a lot with people. Let's say I see them in the office and I don't see any definitive, clear physical symptoms. Lately, because of this new staging system, I do bring up the thought that if you wanted, and this is essentially what I say, if you want, we can go ahead and order an MRI, but it's important to know, like, what are we going to do with that information right now? It's not going to change anything we do, other than the only reason it could potentially is if you really want to be involved in a research study, that's when it becomes more important. Now, if somebody was just like, they're like, I gotta know if there's anything changing, right? Then sure. If you're losing sleep at night because of it, we can go ahead and look to see. But at the end of the day, it's not changing anything that we're doing right now. So most of the time, I say, you know what? Why don't we leave it? I'll see you back in a year. We'll repeat the exam and kind of go from there. And if they were interested in research, that's the main reason why I would say let's do it.
So when you have a patient that is very interested in research, being part of clinical trials, at what stage, are they most, the most likely candidates for studies, and how well are you communicating with your patients as to what studies you think they may qualify for?
Yeah, so I try to ask folks if they are interested in research, because maybe we're doing a study here at IU, but there's sites around us. We obviously have Chicago, we have Ohio State, Vanderbilt, Cincinnati. And so if somebody is really interested in research, we try to get them connected to a site that might be something that they're interested in, whether it's a gene silencing type of drug or what have you. The folks that I'd say are most sought after are going to be your stage 1, stage 2, and the first part of mild stage 3. Because as somebody progresses with Huntington's disease, it's harder to obtain more objective data through clinical trials, and that's not up to me. It's just that's just how it's kind of thought of these days. They use volume of MRI metrics instead of, before we would just do like a physical exam and we would track that, and now they're doing volume of your caudate and putamen levels, and they're tracking all these different aspects, which is harder to do if somebody has more advanced disease.
Other questions? Got a few more minutes. What a great audience, and thank you both for your time and knowledge and sharing.
Yeah, thanks for coming.